Today we have Diane. And what's your last name?
Conti.
Pardon me?
Conti.
Conti. And Diane has an extensive background working with nonprofit agencies in Florida and Illinois. She obtained a Bachelor's of Arts degree in sociology from Augustana College in Rock Island, Illinois. She's dedicated to helping individuals and their families through their journey with neurological conditions. Diane's passion for serving the NeuroChallenge community was fueled by personal experience with her father-in-law's traumatic brain injury. Oh, I'm sorry to hear that. And her work with medical clinics. Diane understands the important role that community resources, education, and support systems play for people with Parkinson's disease, as well as their care partners. She enjoys empowering others to achieve their goals. She's with the NeuroChallenge Foundation for Parkinson's here in Sarasota. So she's the lead care advisor, and she will be presenting this guest lecture today. So we are very thrilled to have you here with your expertise. And without further ado, I'll turn it over to you.
Great, thanks. Thanks everybody for coming out and joining us today on this absolutely gorgeous, gorgeous day. I just got off the phone with a friend up in Illinois, and it's minus 17 right now. So we'll take. I hated to tell her my car is reading 77. So, so yes, I'm Diane Conti. I'm a lead care advisor with NeuroChallenge Foundation, and I'm going to go through this presentation today, talking about optimal ways to fight Parkinson's and a little bit about NeuroChallenge Foundation and who we are. I do see a couple familiar faces out there, so nice to see you. Is anybody familiar with NeuroChallenge? Raise any? No? Okay. Couple people? Okay. So the first thing that I like to talk about is, what is Parkinson's disease? People hear the word Parkinson's and they think of tremor, or they envision Michael J. Fox with his hunched body posture and his dyskinesia with the body thriving, and there's a whole lot more to that. But Parkinson's disease is a movement disorder, and it can affect your ability to complete just regular daily living tasks. It is a chronic and progressive disease. We do know that. It affects the brain and the central nervous system, and because it is a chronic disease, it does worsen over time. That being said, and I'll talk more about this, the rate of progression can vary significantly from person to person. So. Parkinson's is marked by a deficiency of a chemical called dopamine. So what happens is the cells in the brain that develop dopamine, which is the neurotransmitter that sends all the signals to our body to move, they get folded or they die off, they get damaged. And so your body is no longer producing the dopamine that you need. And you can see in this picture over here, on the left side is a healthy brain, and you can see a lot of the red over there. A Parkinson's brain image is on the right-hand side, and you can see that red has diminished. So it's showing that there is a loss of dopamine in there. It's mostly characterized by those motor symptoms that we're going to talk a lot more about, but it also manifests in a lot of non-motor symptoms that not many people are as familiar with. So here are some really early signs of Parkinson's. Before I read through these, I just want to say too, most people, by the time they get diagnosed with Parkinson's disease, they've probably had it for many years. The loss of dopamine can start over a period of time, and some of these symptoms don't necessarily lead someone to think, oh, I wonder if I have Parkinson's. If you start with constipation, might be your first symptom, or the loss of smell. You might have some sleep issues. Those kind of things might take you to a doctor thinking something else is going on, but it doesn't necessarily spark, oh, I have constipation, I wonder if I have Parkinson's. So by the time more symptoms start coming into light and people start putting the pieces together, a lot of times I'll talk with people who get diagnosed, but as they learn more and more about the symptoms, they look back and they'll say, oh, that's been going on 5 years, 10 years, even 20 years. So often by the time someone is diagnosed with Parkinson's, they've already lost 60 to 70% of the dopamine in their body. So tremor, of course, is what we typically think of with Parkinson's. Very small handwriting, micrographia, very small, shaky handwriting. The loss of smell, as I mentioned, trouble sleeping, and there are a lot of different things that can happen with sleeping, whether it's sleep apnea, restless leg syndrome. Many people with Parkinson's have what they call REM sleep disorder, which they actually act out their dreams, or I have spouses that get knocked in the face with arms flailing through the evening and things. The difficulty moving and walking, that stiffness and rigidity, constipation, as I mentioned. Voice is another area that is a big concern for people with Parkinson's. If you think about, as we talk, eat, swallow, all of that requires the use of muscle. And with Parkinson's, because those muscles aren't working as well anymore, you can develop speech issues, real soft, quivering voice, or some swallow issues and things like that. The masked facial expression, sometimes we'll see people who just don't look like they're ever happy. They're not smiling, their faces aren't, showing any emotion, and that's because the muscles in the face aren't working any longer. Dizziness, that is related to orthostatic hypotension, which is just a fancy name for low blood pressure, and a lot of people with Parkinson's will develop issues with their blood pressure, which can cause the dizziness. The stooped and hunched posture, which we'll talk a little bit more about. So those are some of the very early signs. These 4 main symptoms are what a doctor would look for, whether you're seeing your primary care doctor or a neurologist or a movement disorder specialist in the diagnostic process. These are the things that they're looking for. And typically you need to have 2 of these 4 main symptoms for a doctor to give that clinical diagnosis. So again, the shaking or the tremor, that real slow movement known as bradykinesia, the stiffness and rigidity, and then the trouble with the balance and that postural instability, a lot of falls and things. So if you think about a person with Parkinson's being very stiff and rigid, they're hunched over, their posture's already off, we're already in this position, so it already gives us that element to move forward and take a tumble. So those are 2 of the 4 is what the doctors are looking for. Here's a big list of other motor symptoms that can be involved with Parkinson's. And this isn't by any means a complete list, because I can't say enough, every person with Parkinson's has their own set of symptoms. Doctors will say, if you've met one person with Parkinson's, you've met one person with Parkinson's, because it really can vary significantly. The other thing that doctors always say, if you're going to have Parkinson's, you should live in Southwest Florida because we have a lot of resources. So again, the shaking, the slow movement, the rigidity, difficulty initiating movement is another scenario, because the signals in the brain are slower to get to the part of the body that you want to move. Somebody might be standing there and trying to take that first step forward, and initiating that first step might be a little bit delayed, or getting up from a chair to a standing position. Freezing, same scenario. Somebody's been sitting for a little bit and they go to stand up and the signals aren't happening, so they're literally stuck in the chair, or they're standing and their feet get frozen to the floor. So there are some tips that you can do to try to initiate some movement, but the medications do help with that, and exercise and so forth, as we'll talk more about. But freezing is definitely a concern. The overreactivity of muscles, dyskinesia. I mentioned Michael J. Fox. If you've seen any recent videos of him where his whole body is kind of writhing, dyskinesia can be a symptom of later stage Parkinson's, but it can also be brought on by long-term use of the carbidopa-levodopa, which is the main medication for Parkinson's. And Michael J. Fox was diagnosed in his late 20s. And so he's been on the medication for a very extended period of time. So most of his dyskinesia is a result of that long-term medication versus the disease itself. So here's some of the non-motor skills. So again, we typically think about all those physical factors, but anxiety and depression are very common with Parkinson's, and that can be another early onset symptom. The sleep disorders I mentioned, the cognitive impairment. Dopamine not only affects your movement, but it also can help control your mood. So again, the anxiety and depression come into play. Apathy, where you just, do I get up and go to exercise today? I don't care. Kind of that I don't care attitude. Again, part of the fact that dopamine level is down in your system. Under the sensory, we mentioned the speech and swallowing. There's also the loss of smell. Can she come in? Oh, I'm sorry. Pain is another factor, and some visual disturbances. A lot of people with Parkinson's will end up seeing a neuro-ophthalmologist for any visual issues. Want to talk a little bit about the autonomic. So the autonomic system can be much slower for some people with Parkinson's. So that's when things that your body just normally regulates for you, suddenly it's not regulating any longer. Like that orthostatic hypotension. Suddenly you're having all these issues with low blood pressure. You're sitting down, you go to stand up, and you feel very dizzy, lightheaded. Or if you're laying down, you go to a sitting position, and that pressure drops. There are medications to help with that. There are also compression stockings or belts that you can wear to help with that. But it's just the fact of that dopamine reduction causing the body to not control itself. We might have to do some outside factors to help get things moving. Constipation is a huge concern for people with Parkinson's. Again, it's a motor disease, muscle disease. If you think about the digestive system, it's all about muscles contracting and getting the waste through our body. So a lot of people with Parkinson's will have gastroparesis, which is another fancy word of saying slow stomach emptying. So they can take a pill or eat some food, and it might just be hanging out here for a few hours before it gets going through the system. If it's all sitting there and backed up, then the constipation comes into play. Urinary dysfunction, same scenario. Your body just isn't taking control of it itself, may need some help. Sexual dysfunction, another, cause that. This is probably one of the factors, the constipation and the sexual dysfunction, that nobody wants to talk to their doctor about. But there are treatments out there. So if that is something that you or whoever your loved one is with Parkinson's is experiencing, super important to have that conversation with your doctor. Sweating is another issue that can come into play. The autonomic system quits taking control of your body temperature. So sometimes people will have excessive sweating. So there are stages of Parkinson's. Some doctors don't like to really focus on the stages. They like to just focus on where are we at today, what are the symptoms, let's treat those symptoms. But there are mild, moderate, and advanced symptoms. I think one of the reasons that some doctors don't like to focus too strongly on that is, let's say somebody's been in kind of that middle stage, stage 3, doing okay, might need a little bit of assistance with some things, but they have a major fall. And with that fall, they might be stuck in a wheelchair for a little bit, which means they're not exercising, not moving, not getting all of that flow going. So their symptoms start to increase. However, if you are going to physical therapy or whatever the case may be and working on that and improving from the injury, you can go back to stage 3. So if you do progress, there are options if it's from injury or another significant illness. You can go back to an earlier stage. So, and again, all of these stages and the progression, everybody, their rate of progression varies significantly. I've been working with clients who have had Parkinson's 20 plus years and they're still in stage 1. And then I'll have somebody else who gets diagnosed and within a few months they're in a wheelchair. So it really, and there are a lot of factors that determine that too. Other health concerns and how much they follow through with medication and exercise and so forth. So there are about 1 million people in the United States who have Parkinson's, about 100,000 each year that are diagnosed, and they estimate about 1.5 million by 2030, 10 million people worldwide. NeuroChallenge serves 6 counties here, Sarasota, Manatee, Charlotte, Highlands, Pinellas, and Marion County. And in those 6 counties, we know that there are at least 10,000 people affected with Parkinson's. And that doesn't include people who have not been to a doctor or haven't been diagnosed. So we know the numbers are actually higher than this, but this is some of the estimates. Your age is a factor. The older you are, the higher incident of possibility of Parkinson's. 62 is the average onset. However, there are about 15% of people with Parkinson's disease that they had early onset, which is classified as young onset. They're diagnosed before the age of 50. Just in the past few years, that number has jumped from 10% to 15%. And I don't think there's a lot more younger people that are suddenly getting Parkinson's. I think we're getting better at diagnosing Parkinson's, and therefore they're getting diagnosed at a younger age. Speaking of diagnosing, I don't know if it's in another slide, so if it is, I'll skip that slide, but the diagnostic procedure it's kind of not great. We're not super great at diagnosing Parkinson's. We are getting better, but there's not a simple blood test. So it really is the doctor's clinical observation of all those physical symptoms that we were talking about and some of the non-motor symptoms. So if a doctor makes those clinical observations and says, yes, I think you have Parkinson's disease, typically the next step is, let's try some medication, and if it works, that confirms our diagnosis, okay? So it's kind of a gray area there. If you do take the medicine and it doesn't work, then it's kind of back to the drawing board and looking at some other possible neurologic. There also is the possibility that it's a Parkinsonism versus actual Parkinson's disease, and I'll talk a little bit more about those in a minute. But there are a couple of other things that can help with the diagnosis now. Using them alone doesn't create, a 100% diagnostic tool, but in addition to the doctor's clinical observation and trying medications, one is called the DAT scan. Has anybody heard of that? Okay. It's a specialized MRI, and that's where you can get that image where I showed you at the earlier screen. It can show if there is a depletion of dopamine in the brain. Okay. The other thing that's available now, just in the last couple of years, is a skin biopsy. They can take skin biopsy from your shoulder, hip, and knee, and depending how many points come back positive would determine if you do or do not have Parkinson's, to go along with the doctor's clinical observation.
Is there any difference in treatment between someone with genetic and environmental?
No. Yeah, so good question. The environmental factors, we really don't know what causes Parkinson's 100%. There is a small genetic possibility. About 15% of people, have a genetic background. That being said, there are studies out there of identical twins with the exact same genetic makeup. So they both are carrying the gene. One develops Parkinson's and one doesn't. So we still don't know all the answers to that, but there is a genetic factor. We talked about age. So let's talk a little bit about the environmental factors. So we know that repetitive head injuries, concussions, traumatic brain injury, all those kind of things, if there are several of those, it can disrupt the other areas of the brain that are developed, that produce the dopamine. But pesticides, chemicals of war, that's where the main focus is right now. Are any of you familiar with Dr. Dorsey? He has written several books about Parkinson's, and a little side note, he's actually speaking at our expo at the end of March, so just a little plug on that. But he and another movement disorder specialist have written a book called The Parkinson Plan, and their whole purpose behind this book is to show that this is probably a man-made disease, through all of the chemicals and so forth. We know that Parkinson's existed before there was a huge onset of chemicals and things being used, but it has skyrocketed since. So things like Agent Orange, contaminated water. There's a high population of people who grew up in agricultural areas where they used a lot of pesticides. I have a lot of clients in my support groups that talk about running behind the crop dusters and breathing in all that chemical. living near or around, golf courses. The dry cleaning, there are a couple of chemicals that they use in dry cleaning that I don't know where it stands right now. I know at the end of 2025, they were hoping to make a couple of those illegal to use further. But there were huge studies done for people who lived near dry cleaners, or in in large cities where there were apartments above the dry cleaners below. Family, like huge number of family members who had Parkinson's, and it came to light that they all owned, it was a big dry cleaning business, things like that. So, but the herbicides, pesticides, really trying to reduce those to prevent further increase in the Parkinson's diagnoses. But to answer your question again, it doesn't matter what the factor was, the symptoms are going to be the same, the treatment would be the same.
Do you know if it's pesticides and the pesticides are no longer used, how long it's still present in the soil?
No, they're still doing so much testing. There's so much research going on for that. I know like the whole paraquat situation, it was deemed illegal. Now it's not illegal to use. The country that produces it, it's illegal to use there, but they're happy to produce it and sell it to us. There's just all kinds of ongoing research. They find specific genes that might be related, but then from that gene, it turns into multiple clinical studies on how do we split those genes and what causes this and that to match and equal Parkinson's. So we've made a lot of headway in the last 10 years or so with Parkinson's research, but we have a long way ahead of us still. So once somebody is diagnosed with Parkinson's, the first thing to do is if you've not seen a neurologist, or better yet, a movement disorder specialist, that's the direction you need to go. A lot of people get diagnosed by maybe their primary care physician or a nurse who says, I think you might have Parkinson's. Then it's time to go see the specialist. A movement disorder specialist is a neurologist, but they've done an extended fellowship in movement disorders, and their practice focuses only on movement disorders like Parkinson's, whereas a neurologist, general neurologist can treat, epilepsy, headaches, stroke, you name it. Not to say that a neurologist can't treat Parkinson's, it's just there are doctors out there who specialize in just that. We tend to be a kind of a reactive society too. We wait until something's wrong with us to go to therapy. And with Parkinson's, it really is, as soon as you have that diagnosis, get out there and get involved with a physical therapist and a speech therapist. They can teach you. There are a couple of programs specific to Parkinson's. The LSVT Big and Loud program are specialized physical and speech therapies. And then there's also Speak Out and Power Recovery that are two other forms of those therapies. But the therapists are certified in those programs. So they understand Parkinson's and the intention of using big movements to maintain your physical mobility and your balance and so forth. And the same with the speech therapist, speaking with intent, working on swallow issues right away. One thing I will say about therapy is once you're done with therapy, going to therapy, you're not done with therapy. You need to take what they learn, they teach you, take it home, continue doing those. Like that routine needs to be part of your everyday lifestyle. Exercise, starting that regular exercise program. We're going to talk more about that in a minute. Talk to your family and friends because support is super important. And then start planning for your future. This is another place that I think we kind of take the back seat to. We don't think about end of life until we're old, right? Or until some serious illness comes into play. We need to start thinking about end of life from the get-go and talking about, hey, what is our game plan? What do you think here? Do we want to age at home? Do we plan to move to a community? Do we have all of our paperwork lined up? Wills, power of attorney, living wills, all of those kind of things. And to be careful, if you do have all of that paperwork done, to make sure that it's valid in Florida. We have a lot of snowbirds who do those kind of end-of-life paperwork and things in another state. And sometimes it's not valid in Florida. So just keep that in mind too. And just kind of revisit that paperwork every year, make sure everything's up to date, no changes. I had a client years ago, he passed away and his ex-wife got everything because he never changed his life insurance to the new wife. So it is important to pay attention to your documents. And we are fortunate in this area, there are a lot of really good elder law attorneys who can help you with that paperwork. And I do advise to see somebody who specializes in elder law and knows what they're doing versus printing forms off of the internet. Again, they just know how to, dot the I's and cross the T's. So Parkinson's treatment team, obviously you become your own best advocate. You have to share what's going on with your medical team and so forth. If they don't know everything that's going on, then they can't give you the best treatment plan. Care partners, support systems, the neurologist and movement disorder that I mentioned, the therapists, mental health professionals. I mentioned earlier about the anxiety and depression being a big part of Parkinson's, so talking through some of that. The other thing is when we talk about grief, we kind of put that off to end of life as well, and just think about we grieve when someone passes away. But there are times through our life that we grieve, ongoing, and a huge medical diagnosis like Parkinson's can be one of those times. You grieve the fact that you've been dealt this hand and you have Parkinson's, or you may grieve that suddenly I'm not able to drive myself anymore, whatever the case may be. So talking with a professional about those kind of feelings can be really helpful. Nutritionists can be really important. I'll talk a little bit about nutrition, but seeing a nutritionist can be really helpful, especially if you have other health concerns as well, because they can take a look at, we've got this going on, maybe diabetes, Parkinson's, and coming up with a good nutrition plan specific to you. Personal trainers are fabulous if you have access to that, social workers and nurses. Other specialty care that can come into play because of some of those other side effects and symptoms of Parkinson's are the dermatologist. People can develop skin issues, itchy scalp and things like that. Gastroenterologist for all the GI issues that can come up, the sleep specialist, urologist. Alternative medicine. I have a lot of clients who get a lot of benefit from massage therapy. Because their muscles get so tight and so forth, so they see massage therapists, chiropractors, acupuncturists, so those can be options as well. The neuro-ophthalmologist, he's a very specialized eye doctor who deals with neuro concerns with the eyes, the pain management, and the pharmacist. I think pharmacists are a very underutilized resource. They are a wealth of information. If you ever have any question about a medication, whether it's prescription, over the counter, what have you, talk to your local pharmacist. So being empowered to fight Parkinson's. These are some of the categories that we're gonna go through. I'm gonna start with the medication. So once somebody gets diagnosed with Parkinson's, as I mentioned, one way to confirm that that's what we're dealing with is to start them on a medication. And the mainstay medication for Parkinson's is carbidopa-levodopa. It comes in a lot of different forms. The base is called Sinemet, and then there are a lot of others like Ritari and Conti that are extended release formula. There's a patch. There's an inhaler that can be used for like an instant assistant, like for when I was talking about somebody freezing in their chair and not being able to get up. If they do a quick puff of that inhaler, it's a quick, easy dose of carbidopa. It's not long lasting, but it can get you out of that freezing episode. There are a couple of brand new, as of last year, end of last year, some subcutaneous injections. So there's a lot of ways to get the medication, and it's working with your doctor to find out what is best with you. Typically they'll start on just the basic carbidopa-levodopa, but if you get to a point where you're taking more medication or needing higher doses throughout the day, then they might want to work into one of those others. Obviously the subcutaneous injection can be super helpful for people who have trouble swallowing, they can't get the pill down, or they have a lot of those gastro issues and the pill just gets stuck. We've had clients who have done the stomach emptying test, so they go in and they eat something and then they take a picture and sit for an hour, go take another picture of what's happening inside, and sometimes that food or that pill just sits here for hours and hours and hours. And the carbidopa-levodopa is actually digested through the small intestine, so it has a very long way to go before it even gets into your bloodstream and then carried to your brain, where it creates the fake dopamine for you to keep your movements going. It's been around forever. There are other medications out there for sure, but that is still the gold standard. Let's see, taking water with the medication is huge. As I mentioned, long way to travel, so taking it with a glass of water could be really helpful. Taking it on an empty stomach if possible. Some people do experience nausea with the carbidopa-levodopa, so saltines and applesauce and things like that can work. Avoiding taking it at the same time you're eating a high protein meal. Protein and the carbidopa are digested the same way. So if you're taking them at the same time, protein usually wins. So you're not gonna get the full benefit of the medication. And those are other things that a nutritionist can talk with someone about as well. So outside of the regular medications, there are a couple of other treatment options. Anybody heard of the deep brain stimulation, DBS? Okay. So that is an actual procedure where they go in with some electrodes. They find the exact location that they need to place those electrodes to help you move. So you go under. They drill the little holes, they bring you out of a little light sleep so that you can answer questions during the surgery, because they want to place those probes in, like I said, the exact location. So they'll ask you to do things like raise your right arm, or move your forefinger or what have you, tap your fingers, different things like that, so that they can get those electrodes in the exact place. And then there's a lead that goes into kind of like a pacemaker, okay? When DBS first came out, you'd have to go to your doctor to have all the adjustments made and whatever. Now it can all be done remotely or through a phone app. They've just made so much headway. It's amazing how precise they can get. I have many, many patients who have had DBS surgery and said it was, life-changing for them. I have one gentleman out in Highlands County. When I met him 4 years ago, he was in a wheelchair, and now he's up and he runs marathons, and it's just been amazing. Another, said, I have my life back. I can cook in the kitchen again. I can wash my own hair. So it just really gave them significant mobility. There is a lot of evaluation that you have to go through to see that you qualify for DBS, so it's not for everybody.
I had always thought that it was just for people with tremors. But is it? So
tremor is the main focus. Good point, because it's not going to help with anxiety, some of those non-motor symptoms. So it is mostly specific to tremor, to help control the tremor. It is used for Parkinson's and for patients with essential tremor. So again, yes, the very tight movements and tremors and so forth, but not going to be real beneficial for some of those other non-motor symptoms. Mm-hmm. Yeah. And there are, like I say, there's a huge evaluation that you have to go through with a neurosurgeon. You have to go through cognitive testing as well to make sure that you're stable before the surgery. You can have both sides done. Some people will do one side and then the other. Some have both sides done at the same time. So a lot of variation with that, but definitely has been a game changer. The other one is the focused ultrasound. So the focused ultrasound, I kind of think of the analogy I like to use is, the bright sunshine and the magnifying glass and an ant on the sidewalk. And that sun's coming through that magnifying glass and zaps the ant. So in this ultrasound, that's what they're doing. They're coming in and they are actually zapping that part of your brain. So once that's zapped, it's zapped. So it's a very final situation, whereas the DBS, although the electrodes would never be removed, the device can be turned off. So that's a little bit of a difference there. All right, so.
Talking about medication, you had mentioned that Michael J. Fox had tardive dyskinesia. Medications that you see on TV now, like Ingressa, would they be useful for this type
So
of?
for some people, they might try that and see if it works, but usually the tardive dyskinesia comes on after using antipsychotic medications. So if it was an onset from carbidopa levodopa, it may be a different scenario. So, yeah. So exercise, okay, so medication is the first optimal way to fight Parkinson's, okay? You need something to help develop that dopamine that your body's no longer creating for yourself, right? The next thing is exercise. So exercise is the only thing clinically proven to help slow the progression of the disease, okay? So it truly is a use it or lose it, movement is medicine type of situation. So exercise will help you maintain that flexibility, that movement, help with your posture, your balance, all of that. I mentioned a couple of these other things, all right. So there are a lot of exercise options, and this community itself has a lot of exercise opportunity for you. So the more you exercise, the more fluent your movements will be, the slower the progression of the disease will be. Again, we can't give a time frame, unfortunately, but we do know how important it is. Just the other day I was talking with one of my clients in a support group that she'd gotten sick over the holidays and has kind of been sloughing off of getting back into her regular exercise routine. And she said it is taking her twice as long just to get out of bed and shower in the morning. She's stiff, she's slow, her tremors have increased significantly. So she knows that the exercise will help get those kind of things moving and grooving again for her. There are certain types of exercise that are recommended, 30 minutes of this or that kind of thing, but what I always tell my clients is just move. Do what you enjoy for exercise so that you are doing something. If I tell somebody, yeah, you need to do 30 minutes of aerobic exercise and 30 minutes of strength and resistance, and they hate strength and resistance, they're never going to do it. So find something that you enjoy, keep doing it. Whether it's walking, if it is weightlifting, there are 2 exercises that were developed specifically for Parkinson patients. One is pedaling for Parkinson's, and the other is rock steady boxing. In the rock steady boxing, I always get that look like, you want me to box? I already have this, thing going on in my head. It's a non-contact boxing. There's usually, each instructor does it a little bit differently, but there's usually about 6 stations that you go through, and it's a series of movements, whether it's, punching or uppercuts. It works on your stance, your balance, your core strength, your muscle strength, and it also works on cognition, because every time you cross the midline, it's helping your cognition. So there's a little bit of shouting out during the exercise program too, so you're getting some vocal exercise. So kind of is all encompassing. It's a great opportunity. And the pedaling for Parkinson's, doing that rhythmic bicycling. And again, a lot of shout out during the class. Some instructors will do some trivia questions during the class. So you're doing the motion, but you're also thinking and crossing into the cognitive level. Yoga, chair yoga. I love water aerobics, any kind of water exercise, because if you're in the pool and you fall, you're not gonna break a hip, okay? So you're more buoyant in the water, so you're able to move a little bit more, and the water acts as a natural resistance to you as well. So it's really another one of those all-encompassing exercises. Tai Chi, Taekwondo, there's just so much out there. It's kind of hard to come up with an excuse not to exercise. I have one gentleman who his life revolved around golf, and that was his focus. He did not want to give up his golf game. And even when he went to therapy and met with the physical therapist, one of his goals was to be able to maintain his game. So they kind of tweaked the whole physical therapy program to him so that he could maintain his swing and his balance and his strength. So they were still getting all of that therapy in there, but they structured the routine to help him maintain what he wanted to do with his life. So it's important to talk with, the therapist about your goals and things like that too. So there are a lot of in-person exercise programs in the area, and we also offer a whole lot of virtual programs. So it really is hard not to come up with, and I come up with my own excuses all the time, but it is hard to, have a reason to not exercise because there's so much out there and available, and at different levels, because clearly, some people want more strenuous and some people want more of a chair exercise. So the nutrition. First, I want to say we want you to eat protein. I don't want anybody to go home and say, that lady told me not to eat protein. What I'm telling you is to avoid eating protein at the same time you're taking your medication, okay? Hydration. We talked about the importance of drinking with a glass of water when you take your pills to help it get down. But hydration. And people in Florida, we don't hydrate enough. We don't drink enough water as it is. We live in a very hot, humid community, so we need to be drinking. The water is also going to help your body movements be more fluid. It's also going to help prevent constipation. So it has a whole lot of benefits. The doctors that I work with, most of them will say about it, 8 ounce glasses, 8 to 10 8-ounce glasses of water per day. Some doctors will go as far and say half of your body weight in ounces of water each day. So when you start calculating that, and I'm looking, there's a restroom right there, because you have to think about those kind of things. As far as meal plan, really a lot of you are probably familiar with the Mediterranean diet or the MIND diet, which are both really lean proteins, high fruit vegetables, fiber-rich foods. One of the dietitians I work with always tells her people to eat the rainbow. And then I had a client come back to me and he's like, she told me I could eat Skittles. I said, no. She wants you doing green leafy vegetables, red, yellow, peppers, get all those colors into your diet. And making sure it is the lean proteins, fish and chicken. Limiting sugar and caffeine. It's okay to have some, but keeping the limit down. And again, we talked about it'll help control the constipation, dehydration. Weight loss can become a factor for some people with Parkinson's as well. If you can't smell your food, you don't enjoy your food, you don't eat, right? And then just for some people, as the disease progresses, the nutrition and the weight can just continue to decrease. As far as, I usually get asked about alcohol. Some doctors will say it's fine to have a little bit of alcohol, but just to keep in mind that alcohol affects your balance. And obviously you're already dealing with Parkinson's, which is affecting your balance, so keeping that in mind. I get the same answer about that when I get asked about marijuana. For some people, marijuana can be very helpful for the sleep issues, for the digestion, for the mood, and so forth. But again, it is a mind-altering situation, so it can affect your balance. So it's just weighing that out, being aware of that. Education, the saying knowledge is power, so true. Once somebody is diagnosed with Parkinson's, I encourage them to get all the education that they can. NeuroChallenge Foundation offers a lot of, we do at least 2 webinars a month, sometimes more. We do a lot of in-person education programs. This Saturday, we're having a symposium with Sarasota Memorial. In March, we have our expo. There are a lot of wellness clubs. We actually have a wellness club. I think it's next Friday. Actually, it might be today. We have a wellness club at several of our county locations. The one in Sarasota Memorial is doing a 3-part series that starts this month on nutrition. And we partner with All Faith Food Bank to come in and do some education on that. So just learning. We have a YouTube page that has videos of a lot of presentations from our webinars, our symposiums, our expos. We do education forums in the more outskirt counties that we serve, where we bring in speakers. And then there's just, oh my gosh, there's just a wealth of information out there. I do encourage you to go through, national or state or local chapters of some sort of a Parkinson's association, because if you start researching on your own, it's very easy to go down a rabbit hole to get some information that's not always accurate. But if you ever have a question about any particular area of Parkinson's, if you're looking at more of a Parkinsonism, and there are so many things that fall into that umbrella. We have Lewy body dementia, which is almost a flip side to Parkinson's. With Parkinson's, sometimes when you hit the late stages, you can develop some delusions, hallucinations, and things like that. With Lewy body, that's what you experience from the get-go. And then the physical symptoms come towards the end, so it's kind of a reverse situation. MSA, PSP are other forms of Parkinsonism. And again, some of those might start off a little higher with those problems with the autonomic system. Some may mimic straight Parkinson's disease. Sometimes with the Parkinsonisms, the medication is not as effective. So it really becomes a matter of targeting the symptoms themselves and treating the symptom versus the dopamine situation. So, but again, I have a lot of information. If I don't have the information, I'm happy to research for people. So if you're ever looking for anything in particular, whether it's skin, vision, sleep, whatever, just let me know. Social support is huge. If we didn't learn anything else through COVID, one thing we did learn is that we are not meant to be isolated, okay? We are a social being. We need to be out with people. It was really horrible to see the progression of so many people during COVID because they were stuck at home, they weren't socializing, they weren't doing their group exercise and things of that nature. So stay as social as you can. As the disease progresses, people may need to change what their social activities are. For instance, I have a client who they had a supper club. They would get together with 20 people and try all the new restaurants in town. As the disease progressed, it became more difficult for him to eat in person, in public, because of his tremor and the shaking and so forth. And he also had some auditory things going on, and some hearing issues where if there was too much commotion, it was a lot for him to be able to carry on a conversation and so forth. So they've changed their supper club to a few couples at each other's homes, and they just come up with different things and things like that, and so it works. So they're still enjoying their new food and their company and so forth. They just had to tweak the way they were doing it. But trying to stay active. Churches, social activities in your community, whatever the case is, whatever your interests are, any clubs that you can maintain. Attend support groups. We do have several support groups, both in person and online. It's a great place to come together and talk with other people going through similar situation. You really learn from each other, what tips and tricks can you share? What are you experiencing? What did you do for that? Hey, do you know, this exercise class is going on over here? Just that interaction with other people can be really helpful. I did bring some flyers. In Manatee County, there are a couple of support groups. We have one that meets at the Lakewood Ranch YMCA each month. And then we have one, it's with Blake Hospital, that meets at Freedom Village. And that one is more of a lunch and learn. So. But I have flyers for those over there. We also have meetings in Sarasota and a virtual group as well. So there are some specialized support groups too, some virtual support groups, some that are just for caregivers or some who are specific to those Parkinsonisms like Lewy body MSA. So if you're ever looking for a particular meeting, let me know. I can definitely help you with that. Research. So I always put in a plug for clinical research because without research we can't make progress. And as I mentioned earlier, we've made so much progress in the past 10 years with some of the research, new medications, and the new testing, like I had mentioned, the DBS, the focus ultrasound, all those kind of things. So I'm actually in a clinical trial as a non-Parkinson's person because they also need that information to compare with. So clinicaltrials.gov has a list of any possible trial for anything you can imagine on there. Many do have specific criteria and so forth. Bradenton Research Center, right here, occasionally does Parkinson's medication studies and so forth. I can't remember what their current study is. They do have a Parkinson's study going right now. So there are some right in our own backyard even, some are just online. Some will pay your expenses to travel to like UF or something like that, and pay your mileage and give you some compensation. So always keep that in mind as well. And then finally, having a positive attitude. If we allow ourselves to become super negative and I'm not getting out of bed today and I don't care and I'm not going to do this, it will progress much quicker. So fighting with the positive attitude, trying to just be adaptable to what your specific needs and just a few words on NeuroChallenge ourselves. We are a non-profit organization. As I mentioned, we cover 6 counties, and then we do the whole virtual realm as well. We were actually organized, like we came to be from, I don't know if any of you know Dr. Sutherland. He is a movement disorder specialist in Sarasota. And he had a conversation one night with his wife, his late wife, and said, I can't get my patients connected with all the resources that they need in my small follow-up appointments. We need somebody in here to help educate and guide these people, so I want you and your friends to figure something out. So she and some of her philanthropic friends got together and created NeuroChallenge Foundation. So we're not clinical, but we do provide the education, the support services, the exercise programs and so forth. So all of our services are free of charge. We do not receive any state or federal funding. It's all private donors and grant money. So, and we're going on 16 years. So, but our mission is dedicated to improving the life of people with Parkinson's and their caregivers today. I mentioned we're the nonprofit. We do have about 3,500 people in the 6 counties that we cover. So these are just the kind of the core services. The care advising and mentorship. So as a care advisor, I can talk with people one-on-one and just figure out where you're at. Are you newly diagnosed? Have you been in the game for a while? Or maybe I met with you when you were newly diagnosed and things are changing now. So what are the new needs? And just trying to get people connected with all the resources that are out there. We have a mentorship program. Those are individuals who are people with Parkinson's or care partners that you can meet with one-on-one, a phone call, an email, whatever you're comfortable with, just in case you want to talk, like I say, more one-on-one with somebody going through the same experiences. I mentioned the forums and the symposium and the expo. If you have opportunity to attend the expo, it's the largest Parkinson's expo in the country. It's at the Bradenton Area Convention Center. This year it's March 28th. It is a full day event, lunch is included. We bring speakers in from around the state to talk on various subjects related to Parkinson's. This year we're gonna have a little caregiver breakout session. We do some movement breaks in there. We do some voice breaks in there. And we have a huge convention center full of all the pharmaceutical companies that you can ask one-on-one questions with, and community vendors as well. So it's quite an event. It is available virtually too if you're not able to attend in person. So that's me in a nutshell. That's Parkinson's in a nutshell. Are there any questions?
You mentioned early on that it's difficult to find a clinician who can properly diagnose you, that not all neurologists are trained. So where's somebody's first step in trying to get a diagnosis?
So you can get diagnosed by a primary care doctor, a neurologist, or a movement disorder specialist. If you're looking for a movement disorder specialist, I have a list of the doctors in Southwest Florida. There are 2 in Sarasota. Only 1 is taking new patients right now. There are 3 up in St. Pete, several at Tampa at the Fixel Institute. Of course, University of Florida in Gainesville has their whole Parkinson's Center of Excellence. There are a couple in Port Charlotte, one down in Fort Myers. There's even, if anybody's familiar with Synapticure, it's a virtual medical program, and they have a couple of movement disorder specialists on staff too. I wouldn't advise somebody to get their initial diagnosis virtually, but for follow-up care, I think that's a great option. The good thing with them is they can usually get you in a couple months, whereas some of the specialty care locally is about 3 months. I know the Fixel Institute in Tampa right now has a year waiting list. So, and I have a lot of clients that have, maybe a specialist out of state and a general neurologist here or vice versa. So, but the key point is to make sure that you're getting in with somebody who is familiar enough to keep you on the, the high end of the realm of treatment. So,
Thank you.
Any other questions?
I do. I'm not sure that this is something that you might talk about, but I was reading about nanoparticle system. It sounds to me like it's sort of like deep
The deep brain stimulation?
Yeah, except that it uses, it's non-invasive. They don't have to.
I'm not, I don't know enough about that to speak to it. Not being a clinician, sorry.
It's okay.
I can definitely get you some information on it though. If you want me to take your name and email, I can definitely connect you on that. Anybody else?
What do you think about the work of the Michael J. Fox Foundation?
I think they have been just astronomical help in helping get the movement going for clinical research. I think until that organization came to be, we were just dragging our feet on research. I can't remember the exact numbers. There was a recent study that I saw about the amount of dollars being used for Parkinson's versus like Alzheimer's, or what they used when the HIV studies were huge and all, everything was focused, and we were like pennies on the dollar. So just bringing light to Parkinson's, making Congress and government, more aware. They got a lot of research dollars, and I know research right now with current administration has kind of been on a standstill, but they're still, going forward. I think the other thing that was really important too was the change of how people involved with research are interacting with each other. Back in the day, it was each person had their own lab, and they were all doing, like, let's just say cancer research first. An example, every place that was doing cancer research, they would get some finding or something, and they would be like, shh, don't pass that on to anybody. We have the credit here, so we want control of that. We want to be known for what we found. Well, now, and I do think the Michael J. Fox Foundation just made things more global. I think now, if a cancer research has a finding, they might have a group of mice that they sell to the next lab to take it to the next level. So people are much more, everybody's playing well in the playground together. Yeah, and I do give his organization a lot of credit to that too. So.
Another question, you mentioned the DBS for the example, the person in the wheelchair. If a person has diminished motor skills, but not necessarily the tremors, will the DBS help them?
Probably not going to be a great candidate. It really is focused mostly on the tremor to start with. So yeah, if it's something that you're interested in though, I totally encourage you to ask your doctor about it, because they do have all of these stipulations and criteria, but it's also case by case. So definitely, the cutoff is 80. I just had an 82-year-old who had successful surgery. So again, but it really is most beneficial for those tremors. Anything else?
How long typically does it take for the carbidopa to stop working?
So for some people, you can start on that early dose and kind of, get up to maybe 3 times a day or whatever. For some people, that's all it takes. With that dose and exercise, they can maintain that for a long time. It's really individualized, like I was talking before about the progression and so forth. And it's a lot of conversation back and forth with your doctor, tweaking medications until you kind of find that happy place. Because what you want to do with the carbidopa, levodopa, like when you don't have any medication and the dopamine's not in your system, you're kind of having like these highs and lows throughout the day where your body's crashing and you're not able to move as well or your tremors increase. So the goal of that carbidopa, levodopa is to try to stabilize things and keep it as smooth and steady throughout the day. So if you do see the peaks and valleys still happening, or you do notice, hey, at 2 o'clock in the afternoon, my symptoms are really kicking up, or after I take my medication, it's taken an hour for it to kick in. Those are the kind of things that your doctor needs to be aware of so that they can tweak the doses to help you find that smooth spot. And I really encourage people to keep some kind of a journal, a notebook, or something of your symptoms. There's a great phone app, a Parkinson's symptom tracker phone app that you can use too. Because if the doctor doesn't know what you're experiencing, then they can't adjust the medicine or get you on the best treatment plan. But there's not a specific time frame by any means. Good question.
But it is important to take it
It is.
on a schedule.
It is important to take it on a schedule. Absolutely, very important to keep it on a schedule because it all goes back to you want to maintain. If you decide you're going to take your pill at 8 o'clock in the morning and you wake up, you take your medicine, you kind of level out for a while. You're supposed to take it 4 hours later, but you wait till 8 hours later, the dopamine runs out. So your symptoms you're going to crash, your symptoms are going to increase. That being said too, throughout the day, fatigue becomes an issue with your symptoms too, and the medicine can help keep things even keel because, you get tired towards the end of the day anyway. You've been up, you've been moving. But people with Parkinson's, it takes so much more energy to move that the fatigue can become, more problematic. And then you also get the cognitive fatigue. So it's kind of a triple whammy as far as that goes. So again, you really want to keep whatever interval, whether it's, every 8 hours, every 6 hours, every 4 hours, it really does make a difference. If you're kind of, fluctuating the times of the pill, then your symptoms are going to fluctuate a lot more. And it's going to be harder for your body to catch up when you do take the pill because it's crashed below that normal level. Anything else? All right, well, thank you so much for joining me. I have some flyers on the support group, one of our brochures, a couple of our resource guides, which is just a little booklet that has little paragraphs on a lot of topics related to Parkinson's. So please help yourself. My card's there if anybody wants to call me at a later point and talk further. I'm happy to help.